Now, we would like to start the state-of-the-art lecture. The first session will be chaired by Professor Tatsuo Kanda. Professor Kanda, please start.
Thank you. Speaker is Dr. Tiha Pitaravish, is affiliated to NKC Institute of Gastroenterology and Hepatology, Prince of Songkla University in Thailand. Tiha, please.
Okay. Thank you, Mr. Chairman, for your introductions. And good evening, good afternoon that you still stay behind until 5:10. My talk today regarding the state lecture, I will talk about challenging with remaining issue in SBV management. Here my disclosure. So what I'm going to touch on remaining issue in hepatitis B management is expanding treatment indication, and the second one is the treatment discontinuation. Let's start from the first one. Shall we expand hepatitis B treatment indications? This is a current guideline. You can see either SOD, ESO, APASO, and Thailand. They mainly recommend to treat the patient in antigen positive with hepatitis B replication defined by greater than 20,000 IU per ml for SOD, APASO, but only more than 2,000 in ESO and TASO. They also look at those who have active neck-conformation defined by ALT elevation greater than 2 times upper limit normal, except Thailand, we just lay upper 1.5 times upper limit normal. And for ESO, just abnormal, you can treat. And for upper limit, it depends on if SOD, they use 35 and 25 for male and female. The other guidelines still remain at 40 upper limit normal. If those who have liver biopsy, we consider treatment among those who have moderate neck inflammation or significant fibrosis by Metavir F2. For E negative, again, active verification defined as HBV DNA greater than 2,000 or across international guidelines with active inflammation at least 2 times upper limit normal, except ESO just abnormal. And again, liver histology confirm moderate inflammation and significant fibrosis. For those who have cirrhosis, mainly just antigen positive and detectable HBV DNA, except ESO, just S positive, regardless of FT or DNA, they decide to treat the patient. That's the current guideline. Now, if you look at the WHO, World Health Organization, they try to expand treatment criteria from the meeting 2021. You can see the update treatment indication for non-cirrhotic patients. Consider to expand treatment in antigen positive chronic hepatitis B with high viral load and normal ALT that we so-called immune tolerant patient, and also address treatment criteria for the gray zone and antigen negative patient. I will touch on all these two aspects. Let's start from why we want to expand indication treatment to among immune tolerant phase. That means antigen positive, high SBV DNA, but persistent normal ALT, usually in patients younger than 30 years old, because they have some evidence to confirm that immune activity in antigen positive seen in this so-called immune tolerance. That's why some countries, they no longer call immune tolerance. Secondly, we know that early indication events occur early. So the longer you leave the patient getting older, they have more indication of hepatitis B DNA into hepatocyte chromosome. Lastly, we know that when you get older, you have decline in viral-specific T cell population, and that might compromise response to treatment. Lastly, it's always evident to confirm that there is discordance between serum markers and liver histology, and also the list of SCC in chronic hepatitis B infection still remain. This is a meta-analysis to confirm the discordance between liver enzyme and histology among antigen-positive chronic SBV infection or immune tolerant phase. This is 33 study have almost over 9,000 population. You can see even though this patient have persistent normal ALT, but almost 17% of them has significant fibrosis defined by metavier F2. And actually, 5% of them even have advanced fibrosis. Luckily, no in this study have cirrhosis. If you look at another Indian study, 9% of the persistent normality actually have liver cirrhosis. So this discordance between liver enzyme and histology among so-called immune tolerant patients. And we look at the age of the patient. The first one is about the liver histology among persistent ALT, and you look at the age of the patient, particularly if they're older than 35 years old, you can see 1/3 of them have significant liver histology. And if they're older than 50 years old, you can see half of them even persistent normal ALT, but have significant liver histology. And another panel look at the patient who have persistent normal, but sometimes fluctuate borderline upper limit normal. You can see now if they older than 35 years old, 42% of them have significant liver histology, and up to 2/3 if they are older than 50 years old have normal ALT, but sometimes slightly fluctuated. This is a study from Korea. Look at the cumulative incidence of SCC. They confirm that immune tolerant phase or chronic HBV antigen positive high DNA persistent normal ET had higher cumulative incidence of SCC, even higher than immune active phase, but received antiviral therapy. Again, liver-related mortality and liver transplantation also significantly higher among immune tolerant without treatment than those immune active but receive antiviral B therapy. Did another study from China. They looked at 28 patients with persistent normal ALT and had SBV and received nuke therapy. Okay, 14 patients were antigen positive. You can see did they do a PCR in situ in order to detect SBV DNA integration using human chromosome in liver histology. This is a baseline. They found that with antiviral B treatment, you can see 42.5% drop or decline in SBV DNA integration. And those who've been received treatment for 10 years, 3 out of 5 who have available histology, you can see no longer SBV integration seen in the histology. And when we look at for immune tolerant phase, now we move to the gray zone of the patient. According to ASLD 2018, they classify gray zone chronic hepatitis B into gray zone A, that means antigen positive, normal ALT, but DNA less than 1 million IU per mil. As you know that normally immune tolerant patient, they always have a DNA greater than 10 million IU per mil. Gray zone B is antigen positive, elevated ALT, but DNA is just less than 20,000 IU per mil. Gray zone C is a negative patient with normal ALT, but DNA above 2,000 IU per mil, which currently not be recommended for treatment. And gray zone D, E negative, elevated ALT, but DNA less than 2,000 IU per mil. What you can see from the liver histology done in Chinese population who have gray zone population according to ASLD guideline, you can see among antigen positive patients, liver biopsy in gray zone population, 85 to 100% has significant liver histology, which clearly not recommend to treat them. And for E negative, you can see 2/3 also had significant liver histology. Put all together, over 70% of the gray zone chronic hepatitis B have significant liver histology. And did look at the from Korean study again, look at those who mildly active with ALT elevation but less than 2 times upper limb normal, comparing with those ALT greater than 2 times upper limb normal but receive treatment. Again, those who mildly active, just slightly ALT elevation, have sick but no treatment, has significant cumulative incidence of SCC or death or liver transplantation than those who immune active but receive antiviral therapy. And this TOS-B study from Taiwanese, they look at those who consider as gray zone population, receive tenofovir therapy for 3 years, comparing those without antiviral B therapy. This is a multi-center double-blind placebo control. As you can see, after treatment with tenofovir for 3 years, among these minimally elevated ALT or considered gray zone chronic hepatitis B, you can see the treatment population have significant improvement in the term of fibrosis progression, comparing with those receive no therapy. And again, hepatic inflammation, those who receive treatment in this gray zone population or had a trend towards improved necroinflammation, comparing with those without treatment. And when they follow up the patient, they can see that 16% of patients among this population who received no therapy had ALT flare, and 16% require anticoagulant rescue therapy, comparing only 3% of tenofovir treatment develop ALT flare. And so, another study, they look at the gray zone population and try to classify as a low risk and high risk gray zone patient. They put the score according to patient age, patient gender, family history of SCC, and DNA level. You can see from this one. You can see that the patient with high risk score, classified as score equal or greater than 8, have significant higher cumulative incidence of SCC than those who have score less than 8. So this is considered as high risk when the score is about or equal 8 or greater than 8. Look at this one, the treatment. If they look at gray zone patient with high risk score and receive antiviral B therapy, significantly reduce the risk of SCC and have lower incidence of cumulative incidence of SCC comparing with high risk population without anti-HBV therapy. In contrast, those who have low risk, less than 8, even treatment or no antiviral B therapy, no different incidence of SCC and at the very low rate of cumulative incidence of SCC. So, among antigen negative and inactive replication classified as DNA below 2000 and % normal ALT, actually this group of patients, only the patient who has a really slow disease progression and have good outcome. You can see among these low DNA and normal ALT, antigen negative patient, and no incidence of SCC is just about 0.06%. Incidence of developing antigen negative chronic hepatitis is just about 1.1 per 100 patient year. Developing cirrhosis only 0.3 per 100 patient year. But spontaneous weight loss occur in 8% after 10-year follow-up and increased to 44.7% after 25-year follow-up. The mortality from SCC over the 15 years is less than 1.6%. And from other liver-related events, it also less than 1.2% after 15-year follow-up. So this group of patients, inactive replication, normal ALT, seem to be a really slow list of disease progression and really good long-term outcome. So that I will move to the second group of my remaining issue is about treatment discontinuations. Why we want to discontinue? Because you can say that long-term treatment maybe take a list of low-risk side effects and cumulative increased treatment cost. And also, you can see this study from Korea. They look at 894 patients received treatment, just median treatment only 5.2 years. You can see less than 70% adherent we consider poor, and 70 to 90 moderate. You can see only 69% of the patients still have good adherence to therapy. Therefore, long-term antiviral therapy is associated with the impaired, compromise, or adherence to treatment. And this is our own study. What happens when you discontinue a nuke therapy? You can see 63% of the patient can have a virological relapse, defined as DNA above 2,000 IU per ml, and also had a clinical relapse, defined as ALT greater than 2 times upper limb normal with DNA above 2,000 IU per ml. You can see just 1 year post nuke treatment discontinuation from our own study, 63 had virological relapse and 33.7 have clinical relapse. And when we put all together this 22 study, about 1,700 patients, you can see at 1 year after nuke treatment discontinuation, 70% have virological relapse, defined as DNA above 2,000 IU per ml, and 50 to 30% have ALT elevation considered as a clinical relapse. And about 26 to 48% of the patients actually require retreatment. However, the good news is severe ALT flare is rare, and hepatic decomposition also is rare if the patient doesn't have liver cirrhosis at baseline. You can see only one patient in 165 patients with cirrhosis have hepatic decompensations. So I summary all the study. You can see actually hepatic decompensation rate is around 1% in non-cirrhotic patients, but it's 2.95% among cirrhotic. So the first thing that you should learn, you should not discontinue treatment in the patient with cirrhosis at the baseline if they're still antigen positive. Again, non-cirrhotic patients even have clinical relapse, but none of them die from this relapse. Only 1% in cirrhotic patients can die from this clinical relapse. The good thing that we consider is even have some virological relapse and clinical relapse, but 6 to 8% can have antigen clearance after treatment discontinuations. Therefore, in all nuke treatment discontinuation currently, number one, we want a safe discontinuation. That means low clinical relapse and no decompensation and no mortality. Number two, we want to achieve antigen clearance after stopping nuke. We call stop to kill strategy. Let's start from the first one. How can we discontinue nuke treatment and ensure that it's safe with low clinical relapse and low decompensations? Did look at the antigen quantification level by the time that you stop nuke. If by the time that you're going to stop nuke, antigen still above 3 log, don't stop. You can see that over 2 year follow-up, about 70% have virological relapse. But if they less than 2 log, you can see over 2 year follow-up, the relapse is just about 8%. So this is another study from Taiwan. Look at the surface antigen level by the time that you discontinue nuke. If it's greater than 200 or 1,000, you can see just over 2-3 year follow-up, the relapse up to around 80%. Comparing those who have surface antigen level below 200 IU per ml, only 11% have relapse after 2 or 3 year follow-up. And look at this thing. If the patient have antigen below 120 and you discontinue, you can see they increase the cumulative incidence of S-LOD up to over 70%. But if antigen above 1,000, none of them lost surface antigen. So this is our own study. We look the marker, how can we discontinue nuke without the list of clinical relapse. So we look at the correlated antigen below 3 and SBVNA below 2, you can see if the patient achieved it, both marker by the time that you discontinue NUC, none of them develop clinical relapse because we have negative predictive value up to 100%. So if you want to safely discontinue NUC, you just low surface antigen, negative correlated antigen, and negative SBV RNA. Now I come to the last part to achieve HKLN after stopping NUC, which gets stop to kill study. So this one you can see among chronic hepatitis B, if you continue NUCs, the list of HKLN is significantly lower than those who stop NUC. You can see that. Over 6-year follow-up, those who stop NUC, 13% achieve antigen clearance. And when you consider per annual incidence, you can see stop NUC, you have 1.8% per year, and continue NUC only 0.9% per year to achieve HKLN. I will come back this on. This is the predictor of HKLN. You can see no treatment among clinical relapse. I will come back. Because sometimes when the patient have relapse and you early retreatment, you still the chance of having HKLN from the patient. So we come to the RETAC-B study. This is a multi-center study. Look at the e-antigen negative patient who receive long-term NUC therapy and discontinue NUC. You can see after stopping NUC, antigen clearance increase over time, 3% after 1 year after stopping NUC therapy, and increase to 13% at 4 years after NUC discontinuations. What is the predictor of SLOT among this study? You can see those who still have high S antigen above 1,000, minimum a few of them achieve HKLN. Comparing those who have antigen below 100, you can see cumulative increase HKLNs. And also the ethnic. Caucasian population have a significant higher incidence of SLOT than Asian population after NUC discontinuation. Therefore, from RETAC-B study, I would like to propose you that among white population, if surface antigen below 1,000, you can consider discontinue NUC. 41% of them would have surface antigen clearance within 4 years after NUC discontinuation. But for Asian population, because of genotype and longer duration of treatment, we require less than 100. Less than 100 surface antigen, you can see 1/3 of your patients will have antigen clearance within 4 years after NUC discontinuation. But if you want to see more, less than 10, 76% achieve HKLN. But I still recommend less than 100 because only few patients with long-term NUC in Asian population, we have surface antigen below 10. This is a criteria of retreatment for hepatitis B flare after NUC discontinuation when the LT above 10 times upper limb normal or more than 5 times upper limb normal, more than 2 visits or more than 4 weeks or associated with slightly jaundice. These are the old traditional criteria, but the new way to do, I would recommend this one. You can see when you stop NUC, you had 2 types of hepatitis B flare. If the patient after flare have the decline in surface antigen and DNA, we call host dominating flare. This whole treatment. Don't leave treatment until you have decompensation, just monitor closely. But if they have lysing in DNA and surface antigen after the peak and decline of ALT, we call virus dominating flare. This should require antiviral therapy. Otherwise, they're going to have decompensation and unlikely to add S loss. Mr. Chairman, ladies and gentlemen, I'd like to conclude my talk that indication for hepatitis B treatment should be expanded, particularly in e-antigen positive chronic HBV infection, normal ALT, particularly when older than 30 years old. In gray zone chronic hepatitis B, particularly in those who have high risk score, at least 8 or above 8. However, among e-antigen chronic SBV infection with low replicative rate, DNA below 2,000, persistent normal ALT, to consider treatment, you have to balance between disease progression, compliance, as well as cost effectiveness of therapy. Because as you know, the list of poor outcome is so low, but the chance of escalation by themselves also quite high. If you remember, it quite 8 to 44%. Using surface level SBB RNA and correlated antigen to guide discontinuation, you can have a safe treatment discontinuation with the low risk of clinical relapse. Discontinuation with nuke therapy to enhance surface antigen clearance according to antigen level and ethnicity. Below 1,000 in white population, below 100 among Asian population, you have S-lot about 41% and 33% in white population and Asian respectively. Retreatment with nuke in clinical relapse after discontinuation should be considered carefully in order not to compromise the chance of having escalation based on DNA level, antigen level, after ALT flare. If they have decline in surface antigen and DNA, you just continue and observe. They will have S-lot eventually. And thank you for your attention.
Thank you, Professor Tia.
May I ask a question?
Yes.
Yeah. Professor Terra, thank you for your wonderful presentation. And then in one of your slides, a table showed that spontaneous clearance of surface antigen about 10 years, about 8%. I wonder, this is cumulative rate?
That's a cumulative incident and not in all patients. Only in patients with E negative. Low DNA below 2,000 and also normal ALT. When you follow them up, 10 years, 8% had lost spontaneously.
Stop antiviral therapy already with
no viral therapy among these patients.
Okay.
You mean this because this study from Taiwan, they just look. That's why I said in my conclusion that for those who E negative, low DNA, normal ALT, maybe to treat them, you have to balance between cost and effectiveness because they have low risk disease progression. If you remember, 0.0% per year to develop SCC, but they have the chance of S-lot up to 8% after 10-year follow-up.
Okay, thank you very much.
Is there any question from the audience? No? Thank you. Excellent talk, Professor Tia. My session was finished. Thank you very much.
Thank you very much, Professor Kanda and Professor Plato-Bichu. The next session will be chaired by Please wait a moment. Thank you. The next session will be chaired by Professor Shin Maeda. Professor Maeda, please start.
Okay, good afternoon. Next speaker is Dr. Fu Shen Wang. He is Director, Department of Infectious Disease and Liver Diseases, the 5th Medical Center of Chinese PLA General Hospital. His talk title is The Baseline Age for Antiviral Treatment Influences Functional Cure of Chronic Hepatitis B in Young Children. Please start, Dr. Wang.
Okay, thank you, Dr. Shimada. Thank you for your nice introduction. Just a moment ago, Professor Terra gave us a wonderful presentation about the expanded indications for the adult patients when they receive antiviral therapy a lot. Here, I would like to say our patient, the children patient, I think is also the expanding indications for children with HBV infection, chronic or acute infection, when the receive antiviral therapy. Yeah, I'm from Beijing, the National Clinical Research Center for Infectious Disease. Well, I'd like to address the three aspects in the next 25 minutes. The first, I would like to give a brief introduction of the HPV infection among the children worldwide. This slide, all of us are familiar with this slide. When the infant, we call newborn individuals, when they're infected with HPV infection, the chronicity is very high. Is about 90%. When they become a little bit older, like from 1 year old to 5 years old, the chronicity rate is around 25 to 50. When they become adult, generally when they're infected with HPV, by HPV, the chronicity rate is much lower, is less than 5%. This is the general global hepatitis B epidemic. I think everybody knows. I didn't address any issues here, but we should remember the prevalence of surface antigen positive among the children less than 5 years old is still like 0.9% currently. And then there are about 6.3 million children who are infected with HPV, by HPV worldwide. Well, especially in the area like Western Pacific region or Eastern Mediterranean region or Africa region, as well in the Southeast Asia regions as well. Well, due to the administration of blocking mother-to-infant transmission of HPV infection, these administrations has significantly reduced the HPV infection among the infants. But still, this is estimated number. Like in China, we can see when among the children less than 5 years old, the absolute number is about 80,000 cases. So this remains a big problem, because when they cannot receive in-time antiviral treatment, they have a high risk of chronicity. Also, in addition to chronicity, they have a risk to develop like cirrhosis or HCC, although the rate is very low. Well, everybody knows, as I mentioned by Professor Terra a moment ago, the functional cure rate among the adults with chronic HBV remain lower. Only probably for the immunoclearance phase patient with chronic HBV infection, when they receive antiviral therapy by nukes or by interferon or a combination of therapy, the maximum rate maybe the 1/3 of them have E antigen seroconversion, but for the surface antigen seroconversion, the rate is very low. Even 5 or 10 years antiviral treatment, the rate is less than 10%. I mean, the functional cure rate is less than 10%. Well, how about the children? Here, I just address the antiviral treatment for different phases of the children with the chronic HPV infection. According to guidelines or consensus, only the active HPV infection, it means abnormal ALT levels, that should receive antiviral therapy for these patients. Our colleagues and I summarize all the publications regarding the children with chronic HPV infection when they receive antiviral treatment. Less than 40 literatures were published. all the literatures from, and the sample size is not very big. Also, majority of them, their studies are from single center with different antiviral regimens, like the monotherapy by using interferon, or combination of therapy, or response-guided treatment. Well, how about the patients, or we call the immune clearance phase children with chronic HBV infection? From this slide, we can see, just published several years ago, or 5 years ago, or 10 years ago, that didn't find any differences of the functional cure between children and adults. Why? Because most of the children, the age is more than 10 years old. Well, this is a recent publication. We can see, this is also from China, the Hunan province, the children's hospital. When the children were divided into 3 groups, like age 1 to 3, or 4 to 6, or 7 to 17 years old, they find that when receive antiviral treatment, the cumulative functional rate is different. This is about 80-month follow-up visit when they receive antiviral therapy around 2 years, or 2 or 3 years. We can find that different functional cure, we call it just the surface antigen loss, is different among the 3 groups. 1 to 3 is around 62, but 7 to 17 is 17%. This is about the E antigen loss. This is about the DNA clearance or negativity among the individuals. Well, this is our study, recently published in Hepatology International. As we know, when the adult patients with chronic HBV infection, when they are in immune clearance phase, they received 1 or 3 years antiviral treatment, the average rate of E antigen seroconversion is around 30%. But for these children, this is 372 children. The average rate of E antigen seroconversion is 70%. This is for different ages, 1 to 3, or more than 3 to 7, and then 7 to 12, and then more than 12 to 16. This is when they become older, the cumulative rate of E antigen seroconversion were reduced. Well, the most interesting things maybe not this. There is surface antigen loss, we call the functional cure. It's very interesting. Among the 372 individuals, the case with chronic HBV infection at we call the immune clearance phase, the functional cure rate is 39, almost 39, when they received around 2 years antiviral treatment. Well, the cumulative rate is 1 to 3, is almost the same with our colleagues published in China. We just called the younger age of the children when they start antiviral treatment, the higher rate of functional cure, right? Well, this is about the previous slide just introduced the active chronic hepatitis B in children. How about the immune tolerance phase? But anywhere in guidelines or census, they do not actively recommend the antiviral therapy for these children. Well, this is about 8 publications. 8 publications were regarded with the antiviral therapy for these children and the immune tolerance. Well, this is our study. We enrolled around 32 children. They also can be defined as immune tolerance, but we just, according to the definition of immune tolerance, like adult patients. But anyway, some of them with mild elevation of the ALT levels. The maximum is then less 60 IU per ml. When the 32 patients, children, receive antiviral therapy, 18 of them become surface antigen loss, and then with surface antibody appearance. Even we can see within 6 months, at least 5 cases, just when they receive antiviral therapy, they with a viral load is very high, E antigen positive, but within 6 months, the surface antigen loss. This cannot be found in adult patients. Like in adult patients at immune tolerance, it's very hard to suppress the HBV replication by using current antiviral treatment. This is the age. The 9 cases under 3 years old, all of them are cured. But from 3 to 16, also 9 of the cases are cured. Well, were the 32 cases are at the immune tolerance? This is a liver biopsy result. We can see most of them, majority of them, with the mild liver inflammation, or from G1 to G0, G1, G2, or from mild, or even a few cases with severe fibrosis. But so this question, this just address, there are not a real immune tolerance state among these children. Well, how about under 1 years old infant? They should receive antiviral therapy. So far, no recommendations from consensus, from guidelines to recommend antiviral therapy for them. This data is from our team, and then we can see 18 cases, children, when less than 12 months, they receive only namovidin mono treatment. Just at their 20 months, all of them are cured with surface antibody appearance. We call the HBs antigen seroconversion. But this is not RCT study. This comparatively, another group is 11 with the interferon. They are more than 1 year old. The functional rate is only almost 40%. Well, this is a case report. Just 3 or 4 months, they find a high level of viral load, also E antigen conversion, E antigen positive, surface antigen positive, when they receive namovidin treatment for 19 months. He was cured. Well, this is just give us an impression like that. For immune clearance phase, when they received antiviral therapy, if they're younger, their functional cure rate is higher. So the regimen, anyway, the antiviral regimen should be optimized. For the immune tolerance phase, the antiviral therapy is safe and at least effective for some of the children, especially for the much younger children. Well, recently our group did a meta-analysis. We just find about 4 thorough literatures, and then we pick up about 18 literatures. And then we analyzed the different phases or different antiviral regimens, or we judge the data by the different endpoints. And then we compare the differences between the cases 1 to 7 years old versus 8 to 18 years old. How about the data? Well, we can see for the HPV replication suppression, we can see if they are younger, they are much better. This is 1 to 7 years old. This is 8 to 18 years old. This is for E antigen loss. If they are younger, the E antigen loss is higher. Also the same as the E antigen seroconversion. But most importantly is their surface antigen loss. If they are younger, their loss rate of surface antigen is higher than their counterparts with 8 to 7 years old. This is different literatures we can find. We can compare the differences between the 1 to 7 years old or 8 to 18 years old. We found the HPV DNA loss or E antigen loss, E antigen seroconversion, or surface antigen loss or surface antigen seroconversion. If they're younger, we can see the response rate, they're more effective. This is also for different phases, immune clearance phase or immune tolerance phase. Anyway, for immune clearance phase, the functional cure rate in younger children is much better. This is also almost the same in the immune tolerance phase children with HPV infection. This is for different antiviral agents. In my mind, we say if the younger children receive antiviral therapy, regardless nukes or interferon or combination of therapy, antiviral therapy is effective for all the children. Well, this is just summary. From 0 to 18 years old or 17 years old, we can see the chronicity rate from 0 to older ages of the children. We can see that if they're younger, the chronicity rate of HPV infection is much, much higher. But if they received antiviral therapy, totally different. When they receive antiviral therapy, their functional cure rate is much, much higher in the younger children. Well, why? Why they are different between the infants or children and then the adult patient with HPV infection? Recently, our colleagues and I wrote this editorial or published in Hepatology International. We analyzed the reasons according to 4 aspects, like the viral characteristics, immunocharacteristics, or liver growth, or antiviral therapy for this patient. I will say the long story, cut it in short, just one word. When the children, just give you example, they are under 3 years or 1 year old infant, the liver is much, much smaller than the adult, even 1/10 of the weight of the adult patients. When they receive antiviral therapy, there is a full viral suppression. The new proliferated hepatocytes will not be infected by the HPV infection, right? This is just the liver growth for this patient. At the same time, the integration of HPV DNA is impossible when there is a full viral suppression among these children. Simultaneously, in children, the antiviral immunity, especially the adaptive antiviral immunity, is good, not bad, even much better than adult. So this is taken together. These reasons contribute to the cure of these children cases. Well, this is just that we summarized. Like in adult patients, if they are more than 10 years old, the functional cure rate is almost the same as in adult with chronic HBV infection when they receive antiviral therapy. But this younger, the functional cure rate is around at least 20 or 25%. If they are much younger, from 1 to 6, there is 60% of them can become functional cure. How about less than 12 months? In my mind, is almost at least 90% or 100%. So during this period is a golden phase. We just call it a golden phase to initiate the antiviral therapy for these children. Recently, our group just finished an export consensus for children with HPV infection when they receive antiviral therapy. So our conclusion, or based on our data or published data, if they are younger for the children with HPV infection, they receive antiviral therapy, the higher rate of functional cure among these children. Well, we need more RCT studies in the future. So we still facing challenges, but we still face a good perspective in the future. Like we just a moment ago, we say we have finished the export consensus for this patient, but not yet published. And right now, we are lack of like guidelines or some consensus for initiation of antiviral therapy for children, and especially for under 2 years old. Without recommendation of nukes as antiviral agents to treat their cases. And then we still lack of, we are still lack of optimized regimens for treat these patients. So just a moment ago, we just finished a consensus for children with HPV infection during the last year. We almost asked the 60 experts in China to finish this job. And then hopefully this can be published soon in Chinese as well as in English. This is many times of like seminars among the pediatric patients, among the experts, the physicians in hepatology as well infectious diseases. Also, last year we got a key national project. This ongoing project, we hope to enroll 5,000 children with HPV infection at different ages. We hope to figure out some reasons like the clinical cure or related mechanism of HPV infection in children between 0 to 12 years old. And also compared to adults, especially to the mothers who are with chronic HPV DNA and then transmitted to infant or children. Well, I should express my thanks to my colleagues, also thanks to experts in China or also international. Some of my colleagues also in this auditorium. I express my thanks to Professor Zhang Min or Professor Dr. Jin Li as well, the PhD student Dr. Wu as well. Thank you all. Thank you for your attention.
Thank you very much, Dr. Wang. Very excellent talk. Any question and comment? So I understand the younger children is much better to treat HPV. So and the cure rate is very high.
Yes.
So but I think the screening system under 3 years old or 5 years old is very important. So are there any screening system in your country?
Well, yes. In our country, our government pay a lot of attention to reduce the transmission, especially mother to infant transmission, with many administration of measures to do that, to block the mother to infant transmission. But in our study, also I collaborate with some experts in the export like China CDC. All the children when they are born within 12 months they received their test of surface antigen, whether they are positive or negative, especially for the high risk children. It means their mother was with chronic HPV infection. They should receive the test whether their children, whether they have been infected with HPV. Yeah, thank you. Yeah.
Thanks for that fantastic talk. I have two questions. You have interferon among young children as well. For how long? And how about their side effect? Is less than adult or lower than it? And how tolerability?
Excuse me.
Interferon.
Yeah, interferon, yeah. Yes. In general, we initiate the nukes first. But for immune tolerance cases, generally, our experience to treat initiate the animal therapy, nukes and interferon combination, not therapy, but anyway,
Usually how long?
Yeah, it's very important. The maximum duration of interferon treatment is less than 19 weeks. Yeah, this is maximum duration. In generally is about 1.5 year.
I can understand your strategy because you know that when you decline DNA and antigen, you restore TMP5 function.
Yes. Thank you.
Thank you so much. It's a wonderful talk. Made lots of progress, and which is very important for the patients in China. I have a question about your future plan. How to investigate the mechanism related to the high cure rate in the children, and do you think that mechanism would be applicable, could be transferred to the adult?
Yes, very professional question. Thank you. From this project, I also collaborate with experts in the world. Like, I wonder which country are you from?
I'm Chen Feng from Gilead.
Okay. Oh, thank you. And also, your question is, sorry.
The mechanism study.
Yeah. It's a very good question. Probably you know, just last year, our team published the data about the immunological characteristics by using single-cell RNA sequencing to analyze the immunological characteristics in adult patients. Right now, the data will be summarized, and then in children patients, this is immunologically we figure out the adaptive immunity like the CD8, the HPV CD8 T cells maybe play a very important role. Simultaneously, we also investigated some immunocyte as well. On the other hand, we also investigate the virological characteristics, like the viral pool, the viral quite suspicious, or viral integration, or the number of the cccDNA in these cases.
Would you also be able to check the liver, the samples from the liver in the children?
Sure. This is very important. We do not do their peripheral blood, but also simultaneously, we also do their liver biopsy samples. This is very important. In my mind, some experts in Gilead also, we once have some virtual communications during the last 2 or 3 years. We hope to establish some collaboration in this guide, in these aspects.
Thank you so much.
Thank you.
Thank you very much. So, any question? Okay, thank you very much, Dr. Wang.
Oh, thank you, Dr. Shinamato.
So we are going to close this session. Thank you for your attendance.
Thank you very much, Professor Maeda and Professor Wang. This concludes today's program in Room 4. Thank you for your participation.